Thank you very, very much for the invitation to talk with you all today. I am delighted to be here. I'm very privileged to be a new fellow, and I am especially honoured to be the first midwife in this academy. It's an awesome responsibility to introduce you today to the work of midwife scientists in the UK and internationally. My title today, Health for All Childbearing Women and Newborn Infants, is derived, of course, from the Declaration of Alma Ata in 1978. It was a major milestone in population health and was the first to develop the concept of health for all. It was the same year as it happened that I qualified as a midwife, and the health-focused, human rights-based approach was foundational to my thinking and my work. But the question mark at the end of this statement matters. Is it just an unachievable aspiration? Asserting a rights-based approach is not enough. We need to identify and implement the right solutions for all. What mechanisms do we need to achieve this? How can science contribute to accelerating the progress that's needed? I believe we already have some of the knowledge we need to move towards transformative change. And I'm going to talk today about some of how we might manage this. And it's not by doing more of the same. My own research over the past 4 decades or so has been across the fields of breastfeeding, maternal and newborn health, and midwifery, with a long-standing interest in inequalities in health. I've always worked in multidisciplinary contexts, and I've ranged across both qualitative and quantitative methods. Over time, my work's included clinical, public health, health service, and policy perspectives, both in the UK and globally. And today I'm going to describe one of the large-scale collaborative projects I've led, with a focus on safety and quality of care and on midwifery. Some of you I know work in similar fields and will know this well, but many others will come from different fields of science. So I'm going to start by briefly considering the scale and the scope of the challenges. Despite good progress over the last 25 years, maternity and newborn health systems in low and middle and high income countries are struggling to provide the care needed so that women and infants both survive and thrive. The shock of the COVID-19 pandemic and the economic and political shifts of the past few years have multiplied the scale of this challenge, and there's a very real risk to the hard-won progress. Maternal mortality is something of a barometer for the state of a health system. Most women who die in pregnancy and birth and following birth do so from preventable causes that a well-functioning health system would prevent or treat. It's also, of course, an indicator of much wider suffering. For every woman who dies, at least another 20 will have serious morbidity, physical and mental, much of it long-term. And a woman who dies leaves babies and children and family members and communities without a critically important presence. As you can see here, the absolute numbers are very high and very far away from the Sustainable Development Goal target of 70 per 100,000 by 2030. But of course, the real story is one of access to quality care and of stark inequality. These aren't just inequalities between countries, and it's not just a problem for low-income countries. Problems of safety, quality, access, and inequality are a truly global challenge. Even in the UK, there is serious inequality in care. The fact that 4 times more Black women die in pregnancy and childbirth than white women challenges all of us. And regardless of your own field of work, you will be aware that there are currently profound safety challenges in the UK maternity system, with acute workforce shortages of all staff and the ongoing toll of the pandemic. Safety is complex and other metrics matter. In the UK and many other countries, the availability of caesarean section is central to the safety discourse, for example. But these recent data show what is likely to be an unsustainable rise in its use in the UK, especially in the last 10 years and accelerating, that is not clearly related to improved outcomes. Caesarean sections save lives when they're needed, but when they're used unnecessarily, they introduce risk, exposing women and babies to major surgery, recovery time, infection risk, and other complications. In contrast, let's look at effective interventions that are not in routine practice. There is a strong evidence base on these behavioural and organisational interventions, for example. They all have substantive positive impact including reducing mortality, preterm birth, morbidity, and improving breastfeeding and attachment, critically important outcomes. But none of these are implemented in common practice in the UK or in many other countries. Large-scale sustainable change in behaviour of individuals and organisations is likely to be harder than introducing a new technology or spreading one. But my point here is that it's not an either or. Women and babies need appropriate technological interventions and behavioural interventions. The question is one of balance. If we're going to shift the dial and prevent a slide backwards on the progress that's been so hard won, we need to challenge ourselves to both identify and implement different and better solutions that work for all women, babies, families, and societies. I'm going to tell you about a project that set out to do that. About 10 years ago, several global organisations suggested that a Lancet series on midwifery was needed to inform global decision-making. What could midwifery contribute to the complex changes needed to save lives and improve health and well-being in low and middle and high-income countries? Could it help to accelerate the improvements needed so badly? There was experience from several countries to indicate that it could, but it was contentious. It was not well accepted by many, and indeed there was resistance in several countries and from some decision makers and researchers and funders. I jointly led and was the principal investigator over the 4 papers of the main series and the follow-up global research priorities paper. As we developed our multidisciplinary team and talked with senior decision makers and started to gather the evidence, the first thing that happened was we hit a bit of a brick wall. Multiple barriers stood between us and answering that question, not entirely unexpected, but incredibly powerful in combination. The evidence base on maternal and newborn health was divided by discipline and by method and focused on specific parts of the whole picture. Politics and power were influencing decisions, leaving key gaps, many of them around evidence on preventive and supportive care. Midwifery was almost invisible. Even science was confused. Previous Lancet series badged it as obstetrics, completely obscuring its contribution, or even ignored midwifery altogether. We found 109 randomised controlled trials in low and middle income countries of less skilled workers versus none of midwives, leaving a huge gap in knowledge and in policy and practice. Midwifery is inconsistently implemented across the world. While some countries have strong midwifery systems, some countries have no midwives. Many others call their practitioners midwives, but they don't meet international standards. And in others, they are educated to international standards, but their scope of practice is limited. To answer our question on impact, we needed first to understand and define full scope midwifery. We started, as midwives tend to do, with women and babies and what they need across the whole maternity journey, from preconception to the early weeks of life. And then we thought about midwives, properly educated and integrated into the health system, providing skilled, knowledgeable care for both women and babies, partnership working, empowering and strengthening women's own capabilities across that whole continuum of care, care for all, no exceptions, no exclusions. So our global collaboration needed to bring an evidence lens to tackle the barriers, to fill the knowledge gaps about full scope midwifery and inform effective action. And we consciously worked at the interface of these 4 elements. To focus on the science, we searched, identified, reanalyzed and synthesized all the relevant evidence in the field from all the relevant silos, including information from thousands of studies of each of the individual components of care needed by women and babies. This enabled us to measure the overall impact of this complex intervention. The brilliant collaborators we invited brought the range of knowledge and skills needed. Really importantly, the participation of lay and advocacy co-authors and collaborators throughout kept us focused on women and babies. And we laid the groundwork for action by fostering wider collaborative relationships with UN agencies, global advocacy groups and donors. So when the work was published, it didn't just drop like a stone on an unreceptive audience, and we were networked in with their work. In that process, In melding together the varied knowledge bases, it was kind of more transdisciplinary working than multidisciplinary. We developed together a different lens or a new way of seeing by genuinely listening and learning and jointly tackling the methodological and cultural and power barriers. It was truly hard to rethink the issues from a different perspective together, and at times our work was highly politically charged. From this evidence, we built a new evidence-based conceptual framework populated with everything that we were finding from the evidence base. It formed a new wall of quality care for women and babies. This is a very busy slide. I'm only going to address a couple of the key components today. In this top line of practices and interventions, it's the focus of most studies. Going from left to right, it reaches from education, information, health promotion, the care needed by all, through to medical interventions for those with complications. The evidence also shows that other aspects matter. The way care is organised, the values of respectful and individualised care, the philosophy of strengthening women's own capabilities, and multidisciplinary working to ensure all needs are met, all have an impact on outcomes. The framework has been used in a range of ways to assess a maternity system, to develop education standards, to map existing research, which is of course very unevenly distributed. We used it to map midwifery based on the international standards, and that's within the blue line on this slide. You can of course use it to map other disciplines. Full scope midwifery reaches across from public health to clinical interventions, psychosocial as well as physical, for both women and babies together in community and hospital settings, wherever women and babies are, working, of course, in collaboration with a range of other colleagues. Midwives meeting international standards can deliver many of the important public health and clinical interventions for both women and babies, care and support before, during and after the birth, mental health support, post-abortion care, immunisation, breastfeeding support, family planning, it goes on. It's not fragmented between different caregivers or leaving key gaps. From this perspective, it's a complex intervention. It's skilled care for all. The professional and workforce issues matter, but they come later and they are essential for implementation. We then had all the pieces of the jigsaw we needed to answer the question and to evidence the impact of midwifery. Properly implemented and supported, it's a hugely powerful intervention for survival and health and well-being for women and babies and families, enabling their human rights and helping to support sustainable health systems, which is becoming, of course, ever more important. By updating and developing our methods, a paper published last year confirmed the scale of the potential impact of midwifery on maternal and newborn mortality and stillbirth. It's huge. Midwifery can help substantively to leverage some of the most important changes needed for progress towards survival, health, and well-being for all. This work has, for the first time, made midwifery and its potential impact measurable and visible. The question is, what will the system do with it now? The consensus building work we did has helped to start and form action at scale across the world. And it's been affecting all these policy standards, guidance, education, and so on. Just a few examples. On the basis of this evidence, the Indian government committed to work to introduce professional midwives across the country for the first time. WHO has recognised it as core to delivering universal healthcare. They and others are working to build midwifery into health systems across the world and to strengthen it where it exists. And in the UK, this evidence has shaped the radical new regulatory standards for midwives, which are in the process of rolling out across the country. But just like the other forms of evidence-based care that require whole system change I mentioned earlier, all of which, by the way, can be delivered by midwives, to strengthen midwifery for all women and babies, the whole system needs to work together to respond to the evidence. To conclude, our global alliance found that working in this way to solve the scientific, cultural, and political challenges could overcome multiple problems. If we had just accepted the evidence base at face value, we would have found nothing new. Instead, there was something very powerful in our transdisciplinary and cross-sectoral working. To move towards solutions for health for all, especially with the recent global shock, We certainly still need discovery science, but we really need transformative translation science. Further progress in improving health and well-being for all will require a monumental effort, including all of the different groups and sectors, pulling our knowledge to talk across our silos, to identify sustainable opportunities together, and to conduct research to work out how to implement them effectively. I think this Academy is incredibly well placed to explore how to do that, and I look forward to our discussion now and in the future. Thank you very much.